Food is fuel for your body, your mind, and definitely your sport. But let's face it, nutrition is confusing, and the expectations on girls and women to be thin and have a six-pack are exhausting. If you've ever been frustrated with your body, confused about nutrition, obsessed with eating healthy, or guilty when you don't, underate, overate, or overtrained, and overwhelmed with all the pressure, then this podcast is for you. Nutrition can be easy. You can take control of it, but it might start with letting go of control by asking for help and making a change. I'm Lindsay Elizabeth Cortez, sports dietitian and owner of Rise Up Nutrition, where I empower female athletes to overcome nutrition concerns and perform at their highest level, to stop being confused by all the mixed or harmful messages, and finally have confidence in your body as a fierce, fit, and fueled female athlete. Hey everybody, Lindsay Cortez here. We're going to get to the episode in just a moment, but I want to remind you that in the last couple months, I did launch the Female Athlete Nutrition Podcast website. Pretty simple, femaleathletenutritionpodcast.com. I had an old podcast that really marketed and showcased my services with one-on-one coaching, which is at this moment in time, very minimal, unfortunately, but I am still providing content and information and resources to our community of female athletes in need of fueling their bodies better, mostly through the podcast. And so I wanted to create a website surrounded by that. So head to femaleathletenutritionpodcast.com, where not only can you find links and search for episodes to listen to our amazing episodes where we interview guests about all things female athlete nutrition, but also to take advantage of affiliate partners, some discounts that exist by being a listener on the show. You can also get in touch with me if you want to submit a form to be a guest on the show, or even if you don't want to be a guest, but you just want to tell me like, hey, Lindsay, I want you to cover this topic. You can get in contact with me through there. Also, if you are looking for help, we have a resources tab where you can search past episodes of doctors, physical therapists, psychologists, other dietitians, because if you are looking for help with your fueling or with your biomechanics or with your mental health, we've interviewed so many amazing people, so you can head to that resources tab and look some people up, listen to their episode, and then get in touch with them if you need help. So again, femaleathletenutritionpodcast.com. I do want to remind you again about some amazing deals and discounts. Right now, I'm still stuck on Previnex supplements. As a mother of two, I am doing my best to take care of my body, but it is hard. They are young, and my little one, I just gotta say it, he's a hefty little boy, and my elbows hurt every time I lift him out of that crib. He's 1 year old and he's pushing 30 pounds, which is so tiny and yet very difficult to lift up and hold all day long. So I am using the Previnex Joint Health Supplement to help me out. If I don't take it for a few days, I actually notice that elbow pain even more. And then I get back on my supplement routine and just the habit that I have of taking that every morning with water before my coffee. And I notice within a few days, it's feeling better again. So you can get 15% off any Previnex supplement, but I especially love that joint health supplement and would recommend that to any athlete or female athlete struggling with joint pain. Get 15% off using the code RISEUP. And again, that code as well as others are on the website, femaleathletenutritionpodcast.com. Thank you for your patience as there's still some glitches on it. I'm working on it slowly but surely, but the information you find on there is accurate. Let's get to the episode now. Welcome, fans and guests. It's Lindsay Elizabeth Cortez, your host of the Female Athlete Nutrition Podcast. I'm here today with two guests on the same episode, which is pretty rare for me to do, but they are great friends and they come together as a pair. So we have Dr. Bobbie and Dr. Jess, who are two physical therapists doing their best to keep their sanity and enjoy each day in this crazy life. They strive to live healthy most days and see their personal glasses half full. Some days this is much harder than others, as we all know. And they hope to share their perspective with their listeners. They co-host their own podcast, Two Gals and a Glass Half Full. More about Dr. Bobbie. She is the owner and founder of Level Up Osteopractic and Wellness in Naperville, Illinois. She holds advanced certifications in spinal manipulation, dry needling, and completed a fellowship in orthopedic manual physical therapy. She has a special interest in working with athletes, gymnasts in particular, with the goal of treating the whole athlete and keeping them in their sport at the highest level possible. Dr. Jess is the owner and founder of Core Essentials Physical Therapy and Wellness in Jacksonville Beach, Florida. She holds advanced certifications in manual therapy, lymphedema therapy, oncological rehabilitation, and dry needling. She specializes in breast cancer recovery and complex musculoskeletal disorders. She enjoys sharing knowledge with others to encourage transition from injury to leading a wellness-based lifestyle. Through the podcast, Two Gals and a Glass Half Full, Bobbie and Jess co-host, and they are able to share their knowledge and encourage others outside of their clinics on strategies to living a healthier and more wellness-based lifestyle. Thank you both so much for coming on the Female Athlete Nutrition Podcast.
Thank you for having us.
Yeah, of course. Yeah, thank you.
Yeah, and I just appreciate you guys actually introduced yourself to me first, invited me on your podcast, and I've listened to a few episodes, and my episode was released about a month ago. I love the wide variety of topics that you guys have. You know, you're two physical therapists, but your podcast is really just like we mentioned already, just striving to live healthier lives. So you've got such a variety, you know, episodes about toxins, one of your newest ones about like your grains, your own grains, episodes, of course, about being active and athletics and physical therapy, but just what a wide variety. I don't even know how you come up with these topics sometimes.
You know, we like to look at health and wellness as like, it's more than one thing. It's more than nutrition. It's more than exercise. It involves sleep. It involves mental health, nutrition, hydration. You put all of that together and it's going to create a better human being. You're going to feel better. You're going to be able to do more instead of just focusing in on one area.
Yeah. And that's, I think, because we've both been in the clinic for so long now, we see it in our patients. We see all the missing gaps. And so it's like getting somebody out of pain is like literally just step one to being able to get into like fully an active lifestyle. And that's the missing link in our healthcare system, is that we get people just far enough. And then we're like, okay, like best of luck with life. And there's just this gap in knowledge of like, really, it's important to meditate and it's important to drink water and eat good food and make sure that you're working on interpersonal communication, all of the things that will like overall keep your stress hormones down and then keep the good positive hormones up, which keeps overall mood stability, helps with sleep. And then all of that's going to help with injury recovery and prevention. So it really is a multifaceted way of thinking about our bodies and how we can capitalize on having a good day, a good week, a good year, a good life.
I couldn't agree with you more. I see that in my own practice as a dietitian, people coming to me for nutrition advice. And yes, I'm going to help you with your nutrition, but it's not the full story. And I think for practitioners such as yourselves and myself too, you know, I need to know where my boundaries and when to refer out, but having a base level of knowledge about all the things that affect our health is so important so that we can share that with our clients who are in the clinic or in the office in that session with us, and at least get them started in learning that next step that they need to take. And specific to your line of work, when I think about pain that I myself have experienced or have seen other people experience, and I went to a conference once years ago with somebody speaking about pain. And, you know, we think of it as this physical thing. Oh, I have an injury. My ankle swelled up. You know, it's swollen. It's like, okay, yes, we need to bring the swelling down. That's why there's pain, because there's a break or a tear. But how just the concept that pain is also very psychological is just when you, and I'm not going to speak on this, but I remember at the conference, I was mind blown. It was like, is pain even real? But then it's like, no, pain is very real, but it's there too, thinking about the emotional, the psychological aspect of pain and healing in the body as well. I think for you two to really treat somebody holistically is so, so important when it comes to pain management or healing.
A lot of times I'll have to have that conversation and explain that pain starts as a physiological thing, but when it's chronic and long-term, we actually can remap how our brain is, and signals are being sent to our brain telling us we're having trauma, things are happening when they're not. And so there is a huge psychological component to it, but explaining that to a patient in a way of not saying you're crazy
Right.
or you're making this up. You have to explain it in a way of like, yes, you're actually having this, and yes, you're actually feeling it, but this is why. And what can we do to kind of fix that? What can we do to almost reset the nervous system so you're not getting those signals up to the brain that are telling you you're having pain, or fixing the actual problem that's causing the pain? It's figuring out which way it is. Most of the time, it's probably both.
Yeah, and we've done a whole episode on just pain, because it's something that's it's not well understood. And even when we were in graduate school, like the pain science education that we received was very different than the research that's coming out on pain science. It's much, much, much more complicated than, I put my hand on the hot stove, therefore my brain registers pain. Like the brain has to interpret the meaning of everything. Right? So if it interprets something as really, really, really bad because it's had in the past something that it thinks is similar, but really it's not, then you're going to have this like over response of pain. And so it's not this like linear correlation. It can very much have memory components, emotional components, stressful components. All of that plays into what your brain interprets as the output that it's going to say it's going to be this level. It makes it a lot more interesting too. It's like you kind of have to really dig deep to understand somebody and not treat them like they're not crazy. They go to the ER and they're told that, well, this doesn't make sense. Your imaging doesn't confirm X, Y, or Z. Therefore, you can't be in this much pain. And the person's like, what are you saying? I'm lying?
Right.
It's like
the worst feeling.
Yes, a lot of this research is so new. It has not come into common practice yet in a lot of our healthcare system. And so there's a lot of people. I just did an eval yesterday. I mean, totally horrible experience for the last 10 months. And it was just misdiagnosed and pretty much being told, well, at this point, you're probably just a drug seeker. And this individual is not. Zero, not a drug seeker, definitely just misdiagnosed by a lot of different people.
Yeah.
So, yeah, it's tough.
Well, it's great to hear from you that this is new research, because that conference I went to, it was probably around 2018, I think. And like I said, I was mind blown, but it was so new. That's why I can't really repeat what was said, because it was such new information to me at that time. I just know that I, from that moment forward, thought about pain so differently.
Yes.
And even your example, Dr. Jess, about putting your hand on a hot stove, it isn't just immediate pain for everybody. We experience it differently. And, even that example, well, some people might not even experience any pain when they put their hand on a hot stove, and something physiologically is going on, but their brain maybe is focused on something else. And so that psychological component of pain is just crazy. And so I think, again, just your approach to physical therapy and how you host the podcast of, we're not just treating an injury, we're trying to get you healthier all around. And it's so refreshing. Now, with that being said, how the heck do you two know each other? Because you got one in Illinois, one in Florida. And so you host this podcast, obviously virtually, and record virtually, but you guys must go way back.
So Dr. Jess and I went to PT school together, and outside of our roommates, she was the very first person I met. And we just kind of clicked and have been inseparable in that way ever since. So we started day one together in PT school, and it's just been, that was, 16 years ago. Crazy.
Right. Yeah. Yeah. It's one of those, when you meet somebody and they just kind of get you and you get them, and it's okay, this is a friend that graduate school was so stressful. It was tough. And there's days where you just felt like you were just treading water and you had your nose just above water, right? You're still breathing, you're not underwater, but you're a little close to that. And so when you have that one person that you can just get through that experience with, and it's it makes it completely tolerable. That was Dr. Bobbie for at least me in graduate school. I think hopefully it was helpful to her as well.
No, it was great. And it's funny, as the graduate school was about 2.5, almost 3 years. And as we went on, Dr. Jess and I we did literally everything together. So if we showed up somewhere and one of us wasn't there, it was like, where's Bobbie? Is she okay? Or where's Jess? What's going on? Like, it was just like a known that we come as a pair.
Right.
I had a similar experience when I was getting my master's in nutrition with my roommate, Kelly. And to this day, Kelly and another girlfriend of mine, Joy, that I met in graduate school, they are, still my best friends as an adult now. And I think those, when you're in grad school, and you can go to grad school at any age, but it's just that time in your life where you're trying to move forward and find your path in your career. And it takes a lot of work. It's really stressful.
Yeah.
And to have a friend through it all means a lot. And you already have so many shared interests. That's why you're at that place together, right? Even more so than an undergraduate degree.
Exactly.
Yeah.
Yeah.
Real quickly, just for listeners to understand a little bit more about physical therapy. So you were both, you have your doctorate in physical therapy. Did you get that throughout grad school? I don't know when laws change with physical therapy, or if they vary state by state. Was it a doctorate of physical therapy graduate program?
Yes. So after you go to undergrad, at the time when we were going to school, there were a few schools that still offered a master's. At this point, every physical therapist graduates with a doctorate. And it was pretty much that way when we went into school.
Yeah. I actually really think that the profession of dietetics needs to kind of follow in your footsteps in that regard and advance ourselves even further too. We now, dietitians do require a master's degree, but thinking as we started this conversation, kind of knowing that to really treat somebody, we have to really, there's so many things that we need to treat. It's like, okay, we have a doctor of medicine. We should have a doctor of physical therapy. We should have a doctor of nutrition. It's instead of, I think, the traditional healthcare system where we go to our medical doctor for everything. And then if the medical doctor decides to refer out or decides you might need something else, I think really being stronger in each aspect. So I really admire what the physical therapy profession has done to ensure that you are all doctorates of physical therapy and have that title, and can, with that comes more authority and ways that you can truly treat your patient as well. And that's where actually in the dietetics field, we're very limited sometimes in how we can treat our patients.
And you guys have such good knowledge and I've never gone to the doctor and been educated on nutrition, and Dr. Jess and I do educate our patients, but it's a limited thing. I have a patient that says I have these cramps, or I'm trying to do this, or I want to increase I want to increase how much protein I'm eating, and I can give them little things like with cramping, like potassium, like things, but ultimately it's not my area of expertise. So ultimately I'm like, hey, these are good ideas, but you probably want to go speak to a nutritionist or a dietitian, someone that is specialized in that field, because you guys have so much great information.
I agree.
Yeah, and run the diagnostics on it, right?
Mm-hmm.
So
yeah,
that's the big difference when you think of, I'm going to go to my primary care for everything, which right now that is essentially how our model is set up. They're the gatekeepers of your health. But if you have musculoskeletal pain, meaning elbow pain, shoulder pain, hip pain, whatever, they're differential diagnosis. So the ability for that provider to think through, what are all of the different things that could be creating this dysfunction, is really on general. I'm not saying every single primary care is terrible at this, but in general, they don't have the knowledge to go through full differential diagnosis, nor do they have the time to figure it out. So what typically happens, you get sent for imaging.
Mm-hmm.
Imaging is really it's going to rule out a red flag. A red flag meaning a fracture, some sort of bone metastasis, like a cancer, or do you have something that's completely unstable and torn? But if you're not presenting with the signs and symptoms of a red flag in no way, shape, or form, then why are we exposing this extra cost to our healthcare system and to the individual? And typically there's going to be some sort of prescription that's going to be put in there. So now we've got a prescription that you have to swallow. Your organs have to process that prescription, which sometimes is typically some sort of anti-inflammatory or pain medication. Well, the inflammatory process is actually how our bodies heal. So do we really want to stop the inflammatory process when that is what's bringing the repair cells to the site of the injury? So we're going to stop your own physiology, then we're going to block your pain receptors So you're going to overuse. You're not going to learn what's making it worse. You're going to stop the healing. We're going to wait and add costs to get the imaging for a red flag that never even presented as a red flag. And then maybe in 2, 3, 4, 5, 6 weeks, when it's still not better, you get the referral to physical therapy, where we are completely trained in the differential diagnosis of why are you in pain? So now we've got secondary issues that have come up because you've been limping, you've been sitting abnormally, you've been not participating in your typical active lifestyle, so you're getting deconditioned. This is what happens in our current model. And so with a doctoral degree, we're able to see you off the street and say, hey, your elbow's hurting. Let's figure out what's going on, what's positive, implement a treatment plan. If there's red flags, we refer you out and say, I can't confirm that this isn't this. Then we go ahead and refer out. And we're trained in that because our degree has prepared us for that level.
I love that.
So it's just trying to get this shift in mindset in the general population and in our medical system is just going to take a long time, is the moral of the story.
It's going to take more time, but it also, like, it's so brilliant because it's like, yeah, I have elbow pain. Go to the physical therapist. Right?
Like,
and the physical therapist is like, no, this is something else. Okay, fine. But like,
Yes.
It makes so much more sense than going to your primary care doctor for elbow pain,
Right.
you know?
So I wrote a whole blog on it, but there was research that was done looking at musculoskeletal pain. And it was done by doctors. So obviously they're trying to, anytime you look at research, you have to understand that there is some bias in it somewhere, whether who's doing it, who's collecting it, or what point are they trying to show? So they did a research based on, doctors did it, looking at doctors' ability. So they looked at doctors, PAs, and physical therapists and their ability to pass a musculoskeletal test. And it was astounding. It was 80% failed of PAs, primary care doctors. The only ones that passed were physical therapists and orthopedic surgeon. Mm-hmm. Now, most of us are not going to see an orthopedic surgeon first. Most of us are going to primary care. So then they found that outcome. So schools changed what they were doing a little bit. They actually lowered the passing rate, and they did the study again. And still, it was like 78% failed. And that's not to say doctors don't know musculoskeletal. They do. But think about the load they have to look at. They're looking at metabolic disease. They're looking at like more that serious systematic things. Not that they don't care about an ankle sprain, but what are they going to do? Here's medicine. Here you go.
Right.
So when you know what, right, exactly. So if you have a nutrition problem, why wouldn't you go to a nutritionist? If you have a musculoskeletal problem, go to the doctor. If you have go to a physical therapist. If you have a systematic problem, go to the primary care where they can then look at it at a better view. And I was going to say one thing about Dr. Jess was saying about imaging, because they'll tend to do imaging. So many times I have people that have back pain. Their back doesn't hurt when they're laying down. Their back hurts when they're bending over. Their back hurts when they're picking up. Well, they go get an MRI where they're laying down. Mm-hmm. You know, like that's the point you don't have pain. So of course the picture at that point may not tell us what's going on. Also, an MRI is a static picture. It does not show us what's happening in the back while you're moving. So it's excellent to rule out those red flags. It's excellent to kind of make sure there's nothing more serious that requires emergent attention. But in the end, it's not really describing your pain. So just like, you know, for nutrition, just a generalized drink more water, well, that's not going to help if your problem is you're missing some sort of nutrient or something in there.
Right. Absolutely. And, you know, to your point about doctors as well, I feel this in my profession. People are always like, doctors don't get enough nutrition education, but it's like, yeah, because they have other things to focus on. And I just want to be clear with our listeners. I value and respect medical doctors for what they do. Mm-hmm. But that's just it. They're not supposed to do nutrition. They're not supposed to do physical therapy. And that's why it's so amazing that the profession of physical therapy has, you know, figured out, hey, we are going to figure out how to become doctorates of physical therapy. We're going to change the insurance. We're going to change the game here. And I hope that nutrition follows in your footsteps pretty soon.
It'll be good because you know what? It only helps
we support
people.
You in that.
Yep. It only helps them get better faster.
Yeah, absolutely.
Yeah.
So you two, there's a lot of overlap in your clinics and the type of people that you treat, but you do have some specialties that I think are really relevant to my audience as female athlete listeners. So Dr. Jess, we're going to start with you. For those that remember when I read off her bio, this was an area of physical therapy that I didn't even really know existed until I heard you speak on it on your own podcast, is breast cancer recovery and oncological rehabilitation. I think about breast cancer, I think about chemo, I do think about surgery, and I never thought about physical therapy.
Yep.
So I would first like to just kind of ask you, like, how the heck did this become an interest or specialization of yours? Is there a need? Like, share more about the need for physical therapy in whether it's the breast cancer, like, diagnosis process or more just the rehabilitation process.
Yeah. So I didn't know there was a need, by the way. Like when I came out of school, I had no idea. We had one lecture in lymphedema. So that's like, I was like, oh, well, I knew it existed, just kind of like declarative veins tenosynovitis, like it exists, right? So, but when I was a new grad, I had a mentor who she did pelvic floor therapy, and she herself was a breast cancer survivor, and she did a lot with women after breast cancer. And so pelvic floor wasn't really my forte. That wasn't really where I wanted to go. I started off with pure orthopedics and I wanted to be good at that. And she also did a lot with SI joint dysfunction just because of the pelvis. Mm-hmm. And SI joints kind of what holds that pelvis together and kind of connects the spine, and then the hip comes off of it. So I worked with her a lot on that. And my training also included a lot of myofascial work, which is, if you think of like the mobility between the skin and then the muscle, right? So that we've got layers of tissue that slide and glide, and that's what allows movement, or doesn't allow movement when it's restricted. So think scar tissue is when you get some significant restriction between those layers. Mm-hmm. And so she had some patients that had significant scarring, scar tissue restriction. There's something called radiation fibrosis after you have radiation therapy that can limit shoulder range of motion, can limit you being able to take a deep breath, like all of this type of stuff. And so she had gone on vacation. I had this patient put on my schedule that had bilateral mastectomy, meaning both breasts had been removed, no reconstruction. So just, flat chest wall. And for 7 years, she had not been able to take a deep breath.
Wow.
So that's how long it had been since her surgery. She was never referred to physical therapy. And, everyone just said, like, you're lucky you have your life. And so just be grateful, which, yes, like she's lucky she has her life. And she could also have quality too, right? Mm-hmm. You can have both. And I don't think that's too much to ask. So she's on my schedule, and it's obviously just so restricted. I just did some very simple myofascial techniques for the whole appointment. She came back and she was like, I was able to breathe for the first time in 7 years.
Wow.
Like, what did you do? And I was like, some basic myofascial work. So, treated her again. She felt much better. So my mentor gets back from vacation, and I was just like, Janae, what in the world? This lady for 7 years couldn't breathe. Like, this is absurd. Why was she not referred to physical therapy? And she was like, that's why I put her on your schedule. You need to get mad about this.
Yeah.
Like, you need to be part of the change. And I was like, well, what do you mean? Like, she's like, you need to help me get the word out. Like, this is absurd. She goes, I've lived it. I went through breast cancer. I know how hard it is to recover. Like, you need to help me with this. I need that passion from you. And then obviously I was like, well, she was like, nobody's referred. Mm-hmm. Like, you're told you better be grateful, shut your mouth, get out of here. We've got more people to treat. It's like, what? So anyway, that got me onto my rampage of learning, right? So from there, you have to really understand the lymphatic system. So that's a lot of extra training to get certified as a certified lymphedema therapist, because when you have breast cancer, so meaning you've got some sort of lesion growing in one or both breasts, in order to understand, like, has that cancer spread, what they do is they go to the lymph nodes in the armpit and they remove a couple of them, the sentinel node in particular, and they do a biopsy and say, is it positive for cancer or negative? Because if the sentinel node is negative, then the cancer is contained to the breast. That's a big difference in treatment, right?
Mm-hmm.
At that point, we don't need chemotherapy. So chemotherapy is going to be a systemic treatment. So if it has spread outside of the breast, there's a lot of different considerations, but that's where you're looking at a chemotherapy, a higher stage of cancer. If it's contained, then you're looking at no chemotherapy. Surgery, yes, either a lumpectomy where they remove the tumor but keep the breast tissue, or mastectomy where they remove the whole breast. And then from there, you have all of the options of reconstruction or no reconstruction, which all comes with pros and cons. Every part of the way are some really, really major decisions. Radiation, yes or no, it depends. All breast radiation, just a boost radiation. The outcomes for, the person just has to kind of understand, if I do this, my chance of recurrence goes to this percentage. If I don't, it goes to this percentage. It's a kind of a numbers game. It's not, it's not like a sure thing.
Right.
But what it means for the individual is that once that lymphatic system was tampered with, okay, now I have the potential for secondary problems. Lymphedema is something that is not super common. It's not like 75% of people that have had breast cancer get lymphedema, but it is something that, the stats kind of vary. Somewhere around 30% of individuals end up with lymphedema, which just means that they get swelling into typically their arm or breast area. So because if you think of your lymphatic system as, I like to describe it as a highway, where we've got you've got the lanes that you have like the special cars on, because like you've got that pass and you get to go faster than everybody else. Then you've got the lanes with everybody else. So the lanes that get to go really fast, okay, those are going to be essentially your veins. They're only going to pick up a little bit of fluid. They're going to pick up carbon dioxide. They're going to pick up some just clean things, because that's the super highway to get back to your heart. So it's only that vein's going to dump very clean blood back into your heart. Everything else, so all those cars that are like pushing out smoke and dropping crap off of them, those cars have to go through toll booths where they get cleaned, because this fluid is also going to dump back into your heart. So if you take toll booths out of that highway but keep the same number of lanes, guess what happens? That lane can start to back up, because everybody's filtering through less toll booths. Mm-hmm. So depending on the number of lymph nodes that were removed, can really start to create a dysfunction. So sometimes they remove lymph nodes and there's just enough still open that you maintain good flow and you never have a problem. Sometimes you close just enough and you add just enough stress and you get a backup. And that backup leads to fluid, right? Mm. So lymphedema is something that's pretty, relatively common and needs to be managed. And it needs to be managed well so that it doesn't get out of hand. Other things that can happen is that you had surgery, right? Mm-hmm. Like all the muscles in the shoulder can get really, really mad. So all of a sudden you're like, well, I feel like I'm feeling better, but one day I'd like to be able to brush my hair. I'm like, yeah, I think that's a good goal. I think that's fine. Being able to brush your hair. Like there's no reason why you shouldn't get full normalized shoulder range of motion after breast cancer. Nothing was torn in the shoulder. Nothing was cut. There's no fractures. Like it's a clean shoulder. It's just everything around it gets so angry from the intervention that happened, which is surgical sites plus potentially radiation fibrosis. Then you add chemotherapy potentially and you get deconditioning. So it's just kind of that back and forth that can happen.
Yeah. And it makes so much sense when you think about physical therapy. And let's say you have ankle surgery. It's like, yeah, go to the physical therapist after, because you need to work on your range of motion. You need to work on mobility. And yet when we think about a lumpectomy or mastectomy, like I've just never thought of that before. Why? It's the human body. The entire body needs movement in all these different areas. But it also makes sense, like you said, like these patients, cancer, I've never experienced that personally, but I would imagine it just takes over your entire life on a mental perspective, all the decisions that need to be made, the questions, the fears, so much going on that, we're worried about the cancer, not if I can lift my arm up or not. And yet, like you said, months or years later, it's like the cancer's gone. The cancer's beat. You need to move on with life. You need to be able to take a deep breath, to move your arm appropriately. And it's those little things that, it's little compared to cancer. And yet this is a big deal in your everyday life. And that's why, like you said, wow, what a specialty that is so needed. And I want to go back to just the idea that obviously breast cancer does happen in women more often than men. Men can get it as well. But, women, I think, huge stereotype here from my own personal perspective, we don't always get validation for when we are in pain or something's wrong. And we tend to have more of that attitude of gratitude. So it's thank goodness I beat the cancer. Now I've got to get back to life and take care of my family and take care, be with my partner and get through daily life. And we push through and we don't think about those little things.
Right.
Well, I think as women, we tend to put everyone else first, So all of a sudden, okay, it's gone. So now I got to get back to my family instead of still taking that time to focus on you so you can get back to your family fully.
Yes. Mm-hmm. Yeah. And I just one more question for you, Dr. Jess, just about, I'm trying to find the word written down, lymphedema therapy specifically that you were speaking of and how lymphedema can happen. That I really like your explanation of just that swelling and the buildup that can happen. So what does lymphedema therapy look like? What does that involve? How do you get rid of the buildup and the swelling?
Yeah. So there's something we call complete decongestive therapy. So there's 2 phases of treatment. So I start with saying, okay, I measure one arm compared to the other arm for volumetric measurements. So I do circumferential measurements every 4 centimeters up both arms because we're going to have a normal compared to abnormal. And if there's a percentage of involvement that's around 10% or above, so meaning one arm is 10% larger than the other, or we have a spot area that's just really bad. Let's say, they were told, hey, put this compression sleeve on to be preventative, but the compression sleeve has compression from here to here. Well, guess what's not compressed? The hand. Mm-hmm. So guess what can happen? We can create a bit of a tourniquet here at the wrist and then the hand blows up. And now you've got this big old hand. Because you were trying to be proactive with not getting lymphedema, now all of a sudden your hand's huge. So it depends on exactly what's going on. How big is the arm? Is there an area that's just a little bit out of control? And we treat with a combination of compression. So putting compression on might mean that we're doing some wrapping, so graded compression, where I put the bandaging on. Looks like ACE bandages, but they're different than ACE bandages. And so we've got more pressure down here, and then gradually it decreases, and we can kind of help the lymphatic system with added pressure to get the fluid back out so it can filter and then go back into circulation. We also add exercise. So the muscle pump. So every time we contract a muscle, it's going to put pressure on the vasculature. So gentle exercise is really actually helpful for our vascularity and just overall fluid return. So which is why if we sit in a plane for a long time and we're seated and our legs are dependent, we're not contracting our muscles, we can get swelling in the legs. Mm-hmm. There's also pressure changes in the plane that happen as well, but that's something that's very common. So we want to constantly have movement and using those muscles effectively, but in a pain-free range. Then we're also going to include something called manual lymph drainage. And so that's where we're going to stimulate lymph nodes in other territories of our body. So I've got lymph nodes on the other side, right? I've got axillary nodes here. I've got lymph nodes in my groin. I've got lymph nodes in my neck. So I'm going to use lymph node areas that are uninvolved. And I'm going to use a technique. It's a soft tissue technique where I'm going to increase what's called the lymph angiomotoricity, or the rate at which that lymphatic vessel is pumping. So it's a series of techniques where we're going to try and divert fluid away from the armpit of the affected side to a different territory that can filter and clean using a series of techniques that will also increase the pumping rate of the lymphatic vessel in the involved area. It's something that, we're trained to do. And then there's self techniques that we train the patient for home as well. And so the combination of everything, skincare, all of that's super important. So the combination of that, we get the size of the extremity down to a smaller size. Once we hit our goal, which is typically less than 5% involvement, if not full resolution, now we got to maintain that. So how do we maintain? Sometimes we have to use a compression garment daily. So if you see somebody walking around with a sleeve on their arm, potentially a glove, most likely they have lymphedema. Otherwise, they're just trying to look kind of cool, one or the other. So that would be a daytime garment, which is going to be the most common. Sometimes we also need a nighttime garment. Sometimes we also need this pneumatic compression pump. It just depends on the severity. Mm-hmm. Most of my patients, I can get away with having them in a daytime garment, and maybe not even every day. Like we might just use it sometimes. We might use it every day. It depends on their what we call refill. So if you don't have compression, how quickly does the refill start to happen?
Right.
And that's just on a case-by-case basis. So it's like phase 1 and phase 2, get it smaller and then keep it smaller.
So is lymphedema something that ever completely goes away or no, because the lymph nodes have been removed and so it really, and this
it's
is
management.
Yeah, it's management. And this really is why I think physical therapy plays such a big role, because it's management. Yeah. Something that you need to keep up with. Otherwise it'll only get worse and limit you even more.
Yeah.
But you can, you can manage it and have it controlled or contained to move on with daily life in a good quality of life, like you said.
Absolutely. It doesn't stop you. It doesn't stop you from living a good quality life, active lifestyle, everything you want to do. It does mean when we say management, it's typically putting a sleeve on your arm, right? Which can be a bummer. So it's not that simple. It's not like, oh, well, I mean, if that's all you have to do, no big deal. You also have to understand that when you walk around with a sleeve on your arm, and it is there because you went through breast cancer. So think about the emotional connection of that sleeve, right? And everything that you went through, and now this is the outcome, right? That's a bummer. And our common public, people have a tendency to think that your past medical history is their business. And so people walk up, oh, like, why do you have that on your arm? Tell me. And then you kind of relive that trauma there's a lot associated with it. Some people are like, you know what? No big deal. They can ask away. Other people are like, I don't want to wear it in public because I'm just not ready to talk about it.
Right.
And that's where mental health counseling comes in.
That's great. I'm also like, we got to create some cool designed sleeves, some tattoo sleeves. I'm like, I don't know.
There are. Yeah, there's a company that does the tattoos and stuff like that. Though the quality of their sleeves isn't quite there. I've had some people regress with it. Yeah. And so I do typically still refer to like some of the brands that do quality assurance testing, but they have like pink and like single colors. But yeah, there are some that look like a full tatted up sleeve and stuff like that, got this like 80-year-old lady looking like she's all tatted up, which is like super fun.
My husband has 2 arm sleeves for tattoos, and for my 2 little baby boys, we had this onesie outfit that had sleeves, tattoos. And the looks we got in public, like, what is that baby doing with tattoos on their arms? But it was so fun to put them in that outfit. Anyways, I digress. Different topic, but yes, it could be a badge of pride and honor to wear a compression sleeve of look what I went through, and it could also bring up like, something that you don't want to share with public, that you want to not think about anymore. That was a hard time in my life. I want to move on from that. And so, it's very individual what people are going to experience with that. Thank you for sharing that aspect of it. Yeah. And just, wow, how interesting this. I thought I really wanted to bring this to my audience about the importance of physical therapy in breast cancer rehabilitation, going through the surgery, the complications that could happen because of it. This is definitely something that our female audience needs to be aware of. Mm-hmm. So thank you for that. So Dr. Bobbie, I kind of want to shift to you. And again, you guys have overlap in your jobs, and you went to the same PT program. So you guys know a lot of the same stuff, but you do focus in your practice a bit more on the athletic side of things. You love working with athletes, gymnasts, and gymnastics is a kind of passion of yours. And so in your practice, you do a lot of manual therapy, spinal manipulation. I was wondering if we could first start with just some definitions and explanations on those 2 aspects of physical therapy.
Absolutely. So manual therapy, a lot of times when it's spoken about, and even in the physical therapy world, people think of manual therapy as just like putting your hands on someone, which Manual therapy is putting your hands on someone, but it comes with a lot of specificity in that. And so if you think, I think a good example is, have you ever like gone to get your hair done and someone just goes to your shoulders and kind of squeezes and you feel like kind of, I don't know, like your body, you just feel it relax a little bit. And I think there's a lot of important with hands-on therapy. But when we're looking at manual, it is looking at typically 3 different things. We're looking at a joint, muscle, or fascia. So during our evaluation, we're going to look at the joint and see, is it mobile? Is it too mobile, or is it not moving enough? Just kind of feeling how that joint is moving. And if it's not mobile, we're going to use manual therapy and use special techniques to get that joint moving. And when we look at the joint moving, we're not looking at range of motion you can see when you raise your arm up and down. We're looking at the mobility in that joint. So it's a feeling of like, how is that joint moving? And for example, if it's moving too much, we're not going to use manual therapy. We're not going to try to mobilize that joint. We're going to use specific exercises to try to stabilize the joint. Moving to muscle, when we're feeling into muscle, a lot of people think of massage, and it's not necessarily that. Like, we're feeling the muscle. Is it tight? Does it need to be stretched? Are there trigger points that need to be worked out with our hands or with dry needling? It's using specific techniques to affect that tissue that is impaired. And then, so we looked at joint, muscle, and the other is fascia. And Dr. Jess has already spoken a little bit on fascia. Fascia is we have multiple layers. When you look at a picture of your body and you see all these muscles, the picture is going to depict like this one muscle, and then it's separate to this one muscle. In reality, yes, those muscles are separate, but they're all connected with fascia, with like even the muscles, they can kind of intertwine a little bit. So it's not so easy as to say it's just this one muscle. We need to work all the fascia, all the tissue around there and kind of mobilize that tissue. And as she was saying, Dr. Jess was saying with breast cancer, when they can't raise their arm, the same is true at any point of your body. It deals, and especially after surgery, or if someone has been immobilized for a long period of time, like you really got to get all of those tissues moving to get full range of motion. It's not just one, it's not just joint, it's not just muscle, and it's not just fascia. You need everything to go through there. So kind of manual therapy is looking at a specific impairment and then what am I going to do to treat that as specific impairment? Mm-hmm. Spinal manipulation is a type of manual therapy. So you can do spinal manipulation, which means it's looking at the spine itself. So kind of from your head down to your sacrum or down to your tailbone through there. And then you also have extremity manipulation, which is like elbow, knee. And it is a way to mobilize those joints with a quick thrust. So you're actually hopefully hearing the crack or a movement through there. Most of the times, a lot of people think of spinal manipulation as something only a chiropractor can do. But I love the example Dr. Jess always uses is like a scalpel. When you're looking at surgeon, a neurosurgeon and orthopedic surgeon, they're both going to use a scalpel, but they're going in and, looking at different things. So so the same thing's true with chiropractic and physical therapy. And there's other fields out there that can do other healthcare practitioners that can do spinal manipulation. So it is a tool kind of within manual therapy. I don't know, Dr. Jess, if you have anything to add to that.
Yeah, no, I just think that like ultimately when we think of all of the different tools, it's how are we implementing it into our plan of care? So like what do we see as the problem or problems? What are we going to do about them? And what's our intended outcome? And so it's not just one thing ever. And it's really funny, like same thing with dry needling and acupuncture, right? So it's like, it's the same needle, it's a monofilament needle, but it's like, oh, well then does that make you an acupuncturist? No, it's just a tool in my tool belt. But the plan of care, our philosophy on what we're doing to get you to the point that you want to get to is from a physical therapist point of view, not a chiropractic point of view, not an acupuncturist point of view. And those aren't wrong, just not ours.
Mm-hmm. Absolutely. Actually, I had that conversation with a friend of mine recently who had received dry needling and it wasn't working. And I actually asked her, she's tried a lot of things. And I said, well, have you tried acupuncture yet? She said, and I've actually never even had acupuncture. I know very little about it. But she was like, isn't that the same thing? And I said, well, no. I mean, they're both putting needles in you, but they have a different approach and there's different reasonings behind it. I don't know if she subscribes to that type of treatment, but I was like, well, they are two different things. They're both putting needles in you, but they are a totally different approach to it.
Mm-hmm.
So that makes complete sense with the spinal manipulation from a physical therapy point of view versus a chiropractic point of view as well. I just want to share a little bit of a personal story. You know, when I was younger and, you know, active, I started getting injuries. I had 2 ankle surgeries in high school. No, 2 surgeries in high school, 1 ankle, 1 orthopedic, 1 more internal. But anyways, my view of physical therapy at that time and throughout college as well was really just like my experiences were that you have something happen to you, you go to a physical therapist, they would do some like tests on you, tell you to rest it, ice it, elevate it, and do your exercises. That's all I ever got out of physical therapy in my high school and college years, do your exercises. And then I had another ankle surgery when I was like 26 years old. And then finally was exposed to a physical therapist who opened my eyes to what physical therapists can truly do for you. And my ankles, like I said, I had 2 surgeries at that point on the ankle. And like I was having difficult, she was watching me run and she was just like, girl, you got no ankle mobility. And she was actually a coworker and a friend. I wasn't even referred to her. She was a coworker and friend. And one day she took my ankle and she did some manual therapy. And I swear right before my eyes, swelling that I kind of just had lived with, like that's just how my ankle looks, swelling went down and I could move my ankle again. Now I had to do appropriate stretches and exercises to keep that mobility.
Yes.
But it was like, you know, the physical therapy I had received post-surgery, just do those exercises wasn't working without, I needed that manual therapy to push me along further, you know, and she was the first physical therapist who really opened my eyes. She did dry needling as well. She did spinal manipulation, not on me, but just like this wide range of skills that, you know, prior to that experience, I thought physical therapists just told you what exercises to do and shooed you away. And so now I know better.
Yeah. Yeah, I do. So I do a lot of cash base, which means people are paying me cash. They're not using their insurance. They're paying their money to come see me. And during that time, no one's going to pay me a good amount of money to sit there and tell them to do exercises.
Yeah.
So like what we focus on is we do all the hands-on stuff. And I explain this to my patients, and I know Dr. Jess does this too. We do all the stuff you can't do on your own. And at the end, I'm going to give you exercises to do. And yes, I'm going to make sure you know how to do them. I'm going to have you show them. We're going to make sure you're doing them right and correct. But in the end, that's what you can do at home. You don't need to pay me to sit there and watch you do exercises. And so that's how a lot of my patients work is they come and I do what they can't do. And then they're expected to do the exercises, the stuff that they can do. They're expected to do that on their own. And I feel like that's how therapy should be, because then they're only coming once a week or once every 2 weeks, depending on the phase. You know, if it's someone with a really acute headache, they may be coming 2-3 times a week in the first week or 2 to get everything under control. But then again, at the end, hopefully some people with chronic headaches, maybe they're once a month, just they can kind of keep everything managed, and they're once a month come in to get cracked, needled, make sure everything stays pretty good, but they can do the rest of the preventative stuff the other part of the month.
And just to kind of continue that conversation is that, you know, because something regarding the spine and needing spinal treatment and headaches is a symptom. So chronic headaches could be a physical therapy need.
Very much so. Most of the time, what we experience as migraines, not all the time. But a lot of the times what most people experience as migraines has to do with the neck and like the muscles kind of up underneath here, cracking, needling, and working on posture and soft tissue. Those can eliminate almost of the headaches I run into. It is very, very, very rare that I run into a patient with some sort of neck headache issue that I can't make significantly better. And then those are the cases that we need to look more into. Is it a true migraine?
Right.
Because most of the time, what we consider a migraine, the symptoms of a migraine versus cervicogenic headache, which means a headache that starts in the neck, they are very, very similar, and many parts of it overlap. So most of the time when you go to the doctor, they're just going to say you have a migraine. not knowing there's this whole field that we can do to fix this migraine. And some people have them, especially females, when it's on your cycle. There's a lot of people that have it once a month. Well, you know when your cycle is coming. So if you get needled and cracked before that, we may not be able to eliminate it, but we can make some pretty significant changes so it's much less severe.
I love that. And that really speaks to me. Despite being athletic my whole life, I think my computer work, my posture gets screwed up, and I get those posture related headaches. Absolutely. And going back to real quickly, because I know we're running short on time here, but what we're talking about with like the manual therapy and you doing what that person maybe cannot. Yes. I also think this is really important for the athletic community, because an athlete might be receiving physical therapy, but they're still training at the same time, And so it's like they're already doing so much work on their body. They really value that. And I know, going back to, again, my experience with physical therapists when I was younger, that's why it was so frustrating to me. I was doing so much work on my body. I was training 4+ hours a day. I was going to the athletic trainer. I was doing icing. I was doing all those things. And then I would go to a physical therapist wanting them to help me do what I couldn't, and that's what was lacking. And so again, when I finally had the right physical therapist who was just wonderful and trained in that, and it opened my eyes, because I think from an athlete's perspective, that's one of the most frustrating things when you go to a physical therapist, or same with a nutritionist too. It's like an athlete's already knowledgeable about like general nutrition. We're in tune with our bodies. We need the next level. What's the thing I can't do myself? What's the thing that I haven't figured out yet, and I just think that's so valuable for physical therapists to bring that to the table.
I think in athletes, preventative medicine is so important. And to be honest, working with a physical therapist that knows your sport. So for example, I know gymnastics. I did gymnastics my whole life, all the way through college. I coached very high level gymnastics. I know the sport. And I can tell you preventatively, like when I feel a patient or feel a gymnast, like where do I need to work? What do we need to focus on? And what do I see coming? Like what is a problem that's going to be in the future? And then I think a great example is Dr. Jess is a huge runner and she knows running. I don't know running. So I'm not going to be giving a runner the same benefits that Dr. Jess would be giving to that runner. And, vice versa for gymnastics. So I think working with a physical therapist that knows your sport in and out, and sometimes almost has done the sport, because there's another level to knowing the sport when you can actually feel it, when you know what those skills feel like, you know what the fears are, you just know the sport in and out. There's another level of treatment that you can provide for that athlete. So I think really getting into that preventative level, hands-on with an athlete or with a therapist that knows your sport, is so important for those athletes. We're not going to prevent everything, but we can definitely prevent a good amount of stuff.
Yeah. And I can say the exact same thing about nutrition in many different regards as well. But it's like, I loved when my business was a bit more active, I loved having my coworker Jenna work with clients, because Jenna was actually a plant-based dietitian and I'm not. And like, I eat plant-based meals from time to time. I enjoy that. But when I had a client that was like 100% plant-based, well, Jenna really got, because Jenna made 100% plant-based meals all the time, so she got it on a different level of what that really looks like in the grocery store and your shopping list, and being, how to really make that work all week long and not get bored of the same things over and over again. And so I agree with you. We don't have to go through the exact experiences of our clients, but it certainly always helps. So
wonderful. And it's not that I can't treat runners, and it's not that I can't, but it's not my specialty. And if I know someone that can, like, I'm going to refer it. And it doesn't mean I'm not a good therapist, or, for example, like, I love how you refer out. It almost makes you a stronger therapist, because then you can be really strong in what you do know.
For sure. Absolutely. Well, Dr. Jess and Dr. Bobbie, this has been really wonderful conversation. I think enlightening on a few different fronts, and just great to expose the profession of physical therapy and all that you can do. And that now that I'm an advocate for it, after, again, that was in my youth that I struggled. And you two are exactly the type of physical therapist that I would want myself to be treated from, my family, my friends, and all my clients. I can see that you're doing really wonderful work for athletes and women. So we end every podcast with a few fun questions. I'm going to ask the question. We'll have Dr. Jess speak first and then Dr. Bobbie. Fun questions, rapid fire. If there's one food you could eat every single day for the rest of your life and never get sick of it, what would it be?
Probably pizza. I love pizza. It's so good.
Mm-hmm.
Potatoes, any type of potatoes. I am known as the potato queen.
You live in Illinois, right?
Yes, I do.
There's potatoes there, right? They grow there? Okay. Yes. Makes sense. Very
I like any type of potato. I am not I'm not against any type of potato.
Love it.
them all.
What is your favorite sport to participate in?
A sport is tennis. Yeah. Not that running's not a sport, but tennis, I love the competitiveness of tennis. Love it.
Yes. Yeah. How about you, Bobbie?
Gymnastics, and been my whole life. So all I know, if you require a sport with a ball and some hand-eye coordination, I am as good as a 5-year-old out there trying to learn it.
And how about as a spectator? Is it the same or different? What's your favorite sport to watch?
For me, it's the same. I love watching tennis.
Yeah.
Not that I have time to, but.
For me, I think I don't have a specific sport. Like, I do like watching gymnastics, but it's in person. Mm-hmm. I love the experience of it in person. So like anything like baseball game.
Yeah. Yeah. And not many people get to watch gymnastics in person.
Yes. So like I love in person watching it.
Yeah. Amazing. All right. And then our final question, which is a difficult one, but if there's a female athlete out there that you want to give a shout out to for being an inspiration or role model, she can be somebody in your personal life or somebody more well-known to the public. Who would that be and why?
I would definitely say there's a ton of professional athletes out there that are amazing, but I would say growing up playing tennis, one of my good friends, her name is Kim, she had such composure at such a young age on the court. It taught me that importance that even under stress, even when you're young and you feel like you can act immature, that hold your composure in front of your audience and play it through and see it through. That was just like a really big lesson that I learned. I mean, our coach would tell us to do it, but then I just watched her live it, and that always just stuck with me. Like, it really big time stuck with me.
I love that.
Easy one would be Simone Biles, obviously, for gymnastics. She's done a lot for the sport. She's done a lot for mental health, just in everything in general. But there were 3 athletes that were favored for the Olympics, and at the Olympic trials this weekend, 2 tore Achilles tendon, and the third one hurt her knee. I don't remember quite what she did, but those 3 athletes were favored to be on the Olympic team and to have an injury at that point in your life. And all 3 of them have come out, and they're just being great examples for girls, great examples on how the sport isn't their life, the only thing about their life, and they'll come back from it. So I think they're just going to be a great example for gymnasts following them, that kind of watching that dream you've worked for your whole entire life just being taken away from you at that moment when you're supposed to have made it. I think watching them come out of that will be such a great inspiration for girls.
Absolutely. Well, thank you both so much. And again, to our listeners, we'll include in the show notes link to their website to listen to their podcast where they're sharing more, not just physical therapy, but just tips on living a healthy lifestyle. Thank you, Bobbie. Thank you, Jess.
Of course. Thank you.
Thank you, Lindsay.
Well, everybody, thanks for listening. I really hope you enjoyed that episode. And if you did, if you are a true fan of female athlete nutrition, then I would love if you could support our podcast by spreading the word. Share a review on your listening channel, give us 5 stars. It really helps get the word out and get the show more views to positively impact others. Also, you can support the podcast by joining our Patreon. Head to patreon.com/female athlete nutrition to consider a donation, or even better, join our membership where you get extra monthly content and perks. we don't want you to simply listen alone. We want you to be a part of a community and a movement of fierce, fit, and fueled female athletes. So patreon.com/female athlete nutrition is where you can do exactly that, learn more, and join. A huge thanks to our affiliates and partners as well. Once again, Previnex, Inside Tracker, Orgain, Practice Better, Jen and Carrie. Please go check them out, and their links in the show notes where you can get deals and discounts. Last, be sure that you do more than just listen. If you need help with fueling, it's time to take action. Head to my website to learn more. You can either book a free call with me to learn more about our coaching programs and how we can work directly with you, whether it's the fast track or otherwise. Or you can take our online self-study course, Female Athlete Nutrition. You can literally sign up and gain access right now. You can explore our downloadable products, including the Red S Recovery Guide, High Iron Fueling Guide. Or if you are a coach of a team, check out our brand new Coaches Toolkit for teams. You can also just learn more. We have a blog, a Red S quiz to see if Red S is affecting you. If you need help, I want you to get help fast. Too many girls and athletes struggle with nutrition, but you don't have to any longer. You can rise up with the power of nutrition, take action today in any of these avenues, and become fierce, fit, and fueled. Links in the show notes, and we'll see you next time.